Today we are going to take a look at some of the structures in the retroperitoneum. And when we think of the word retro, it refers to what is behind. Right now, the whole world is having trouble because of a retrovirus, or a virus that comes in as a retrovirus, and then it is going to move from an RNA virus and become a DNA. What we are looking here is really at structures that are at the back of the peritoneal cavity. And that area is referred to as the retroperitoneum. The retroperitoneum, there's an area that you have to know because there are some important structures in the retroperitoneum, and people will come to you with problems that are related to diseases occurring in the retroperitoneal area. Now, usually when we think about the retroperitoneum, we have to think about the boundaries of the retroperitoneum. So the retroperitoneum is going to be covered by peritoneum. So peritoneum covers all of these structures, and this is going to be the posterior peritoneum. There's going to be an anterior peritoneum. This that you see here, this is part of the anterior peritoneal wall, right? So this covers, and then the peritoneum covers the organs as well on the inside. So the posterior part of the body wall, which is right here, this is peritoneum. And what covers the structures, what is going to be plastered down, covering down the kidney, is also peritoneum. So when we talk about the retroperitoneum, we are talking about the structures behind that peritoneum. And so that's one part to remember. The other thing is we must define the extent of the peritoneum. How big is it? The peritoneum has a roof, and in the roof is this structure here, which is called the diaphragm. So the diaphragm helps in forming the roof. And there are structures within this peritoneum, and inferiorly, the retroperitoneum has a floor, and that floor is formed in the pelvis. So if we take the pelvis here we have a pelvis. Superior to the pelvis, we have the lumbar vertebra. So the lumbar vertebra, they are going to form the posterior skeleton of the abdominal section of the retroperitoneum. And then we have the pelvic section of the retroperitoneum. Superiorly, the roof really is made of soft tissue. So we have a soft tissue roof. We have a floor which is buttressed by bone, and we also have a floor which is, as it were, supported by bone as well. Now, when you look at the pelvis, all you see is that there's a hole inside it. But what you are noticing is a pathway, and there are muscles that help to control the inferior part of this peritoneum. And the muscles are named in relation to the bones that are within the pelvis. So what are these bones? Anteriorly, we have the pubic bone. Superiorly, we have the iliac bone. And inferiorly, we have the ischium. So the ischium, the pubic bone, and the iliac bone, they help in forming a half of the pelvis, as it were. These three bones, they are referred to as the os innominatum. Os innominatum means nameless. Os is bone, innominatum, it's without a name. So it's a nameless bone, and individually it's composed of ilium, pubic, and ischium. Posteriorly is the sacrum. Superiorly is a lumbar vertebra, and inferiorly we have a little component that is made of about 4 coccygeal bones, right? Now, the floor of the pelvis is formed by muscles that go from the pubic bone to the coccyx. So from the pubic bone to the coccyx, we have the pubococcygeus. From the ilium to the coccyx, we have the iliococcygeus. And the ischium, that's the other bone, from the ischium to the coccyx, we have the ischiococcygeus. So what happens is that these muscles form a diaphragm inferiorly, and that diaphragm is referred to as a pelvic diaphragm. So inferiorly, we have a pelvic diaphragm, and superiorly, we have an abdominal diaphragm. A little bit about the roof. The roof of the retroperitoneum is very important. As we said before, it's formed by the diaphragm. And you need to remember what the diaphragm is made of. The diaphragm is really mesodermal in origin, and it has components. The biggest, the most important part of it in terms of its embryology is that it arises from the septum transversum. So the septum transversum gives rise to a lot of the tendinous structures within the diaphragm. But it is also assisted by membranes like the pleuroperitoneal membranes that form a big part of the diaphragm. And also, there are peripheral myoblasts within the diaphragm. And these peripheral myoblasts, they interface with the thorax. And then there are small components like mesenteric elements related to the esophagus, as well as the aorta that will help in forming the diaphragm. And don't forget that the diaphragm is buttressed by crura. So there are crura, one on the left and one on the right, and these crura help in supporting the diaphragm. So remember that. Remember again the nerve supply of the diaphragm. Nerve supply is from the phrenic nerve, and that becomes very important when the phrenic nerve is paralyzed. All right, now posteriorly, there are some muscles, and let us take a look at them. The most medial is this one, which is really the psoas muscle. And remember that the psoas has quite an origin. It is really a muscle of the lower limb. And this muscle inserts up as high as the body of the 12th thoracic vertebra. So remember, don't forget that the peritoneum is going to cover it. But the psoas is a very important muscle, because within the psoas you have the lumbar plexus. The psoas is not a muscle, therefore, that you can say, let us just take it out because it has an abscess in it. We want to preserve it, because if you take it out, then you stand to be taking out the nerves that are present within the psoas. And those nerves are 6. There are 6 nerves within the psoas. They are formed within the substance of the psoas, and so they are the lumbar plexus. And if you will remember, the nerves that form the plexus, 2 of them have 1 root, 2 of them have 2 roots, and 2 of them have 3 roots. So it's pretty easy to remember. This one that you are seeing here, these 2, this one that we have up here, is likely to be subcostal, but this one here is going to be L1, a part of L1. And L1 has both the ilioinguinal and the iliohypogastric. Those two nerves have one root, which is L1. And then we have two nerves with two roots. One of them runs on the psoas. You don't really see it so well in these arms. Here is it. Here is it. This is one of the nerves. This has two roots. This is the genitofemoral. And you can always tell the genitofemoral because it runs anterior to the psoas. The other nerve with two roots is the lateral femoral cutaneous. And you can tell those nerves because they run on the iliacus. So I'm pulling them up here. The lateral femoral cutaneous. The roots of this are L2 and L3, and the roots of the genitofemoral, that is going to be as well two roots, and this is going to be running on the psoas. And then there are two big nerves here. This is quite a big nerve. It is lateral to the psoas, and this is the femoral nerve. And then medial to the psoas is another nerve, and this is the obturator nerve. This root body is going to be L2-3, and the femoral is L2-3-4. So those nerves are important because they are formed within the substance of the psoas muscle. Now you also need to remember where the psoas is arising from. The psoas is arising from the lower border of T12, but it also arises from the lumbar vertebra, the transverse processes, and it also arises from arches. If you look here, you can see like a fibrous arch, but there are fibrous arches that hook up the superior part of each lumbar vertebra with the inferior part. The hook allows blood vessels to pass in the spaces between. Here I have a lumbar vertebra, and as you look at the lumbar vertebra, you notice that the inferior part is prominent and the superior part is prominent. And there is actually a groove between the two upper and the lower part. And there is a lumbar groove. So what happens is that between the two parts you will have an arch which is really made of collagen, and that forms one of the connections for the psoas. So the psoas is attached to the vertebral bodies. It is also attached to a tough structure which is present behind, so between the vertebral bodies, and that tough structure is the disc. So it is attached to the body, the disc, to the arch made of collagen, and also to the transverse processes of the lumbar vertebra. So don't forget those four attachments or origins of the psoas. Remember that the psoas is that muscle with the lumbar plexus, with 6 nerves, 2 being 1 root, 2 roots, and 2 3 roots. Alright, so that's the psoas. And the kidney rests on the psoas. Now, lateral to the psoas is another muscle which is right here. And this muscle which is right in this area here is the quadratus lumborum. So quadratus lumborum, this is quadratus lumborum. This muscle right here. And it arises really from the 12th rib, from the inferior part of the 12th rib. And then it goes right down and is inserted. You can see the tough, strong iliolumbar ligaments that are right here. and also it has an attachment to the iliac bone. So the quadratus lumborum is pretty important. Below it we have the iliacus, and this is spreading out laterally. There is one other little muscle that I should remind you of, and it runs, it's not always present, but sometimes it is. This specimen doesn't have any, that is really prominent, but sometimes you would find a little muscle in the psoas, anterior to the psoas, and that is referred to as the psoas minor. And it goes down and is inserted into the iliopectineal ligament. And the iliopectineal ligament is, if you look at the pelvis, here we have the small part of the pelvis, which is really the true pelvis. This part section here is referred to as pelvis. Pelvis means basin or bowl. So here we have a little basin or bowl, and then at the junction between the true pelvis and the false pelvis, we have a line. So this line is almost like a pelvic ring, and that pelvic ring starts from the sacrum posteriorly and runs anteriorly. So anteriorly, going from the sacrum anteriorly, we have a line here which we refer to as the arcuate line, and then we get to the junction between the ilium and the pubic bone. So this junction is referred to as the iliopectineal junction, and because it is prominent, as you can see on this side here, is the iliopectineal eminence. And so in this area, we are going to have collagenous tissue, and it is into that tissue that the psoas minor is attached. Psoas minor is supplied by the L1 lumbar vertebra, whereas the psoas major is supplied by L1, L2, and L3 nerves. Now, as you go laterally from the psoas major, going laterally from the psoas major, we're going to get psoas initially, and then we're going to get the quadratus lumborum, and then we are going to get to a part of the lateral body wall. And this lateral body wall is going to have, the lateral body wall has three muscles. There is the external abdominis, there is the internal oblique, the external oblique, the internal oblique, and the transversus abdominis. So this muscle on the inside here, this is really a part of the transversus abdominis. So it also is going to form a part of the posterior relation for the kidney. So the kidney, as it were, is lying down on the psoas medially. In the middle, we have quadratus lumborum, and laterally, we also have transversus abdominis, and with superiorly
the intervening fascia,
with the fascia,
the thoraco,
right, and then superiorly now we have our diaphragm, right. So some people think probably about 50% of the kidney on the posterior wall is formed by the diaphragm, right. So that's a little bit in relation.
You did the nerves and vessels posterior,
we did the nerves. Okay. We did the nerves, yeah. Right. Looking here, this particular specimen really shows the anterior lordosis of the lumbar vertebra. And in this lordosis, when you look at the discs contribute particularly to the lordosis. The anterior part of the disc is much wider than the posterior part, and that contributes significantly to some of the lordosis that we are seeing here, which is an anterior bowing of the lumbar vertebra. Now, resting on the vertebra, a little bit off center, is the aorta, and this is what we have here, aorta. So the aorta is coming down here, and the aorta is going to be the abdominal aorta. Now, this abdominal aorta is going to start in the vicinity of about the 12th level of the 12th thoracic vertebra, and then it is going to go right down, and at about the level of L4, which is right here, you can see that it is divided, right? So, and that is the official point of division of the aorta, L4. Now, as the aorta goes on,
you see the IVC,
right, and just beside it, just you see this dark structure, which is right here. This is the IVC, inferior vena cava, and the inferior vena cava is a little, if you notice it, it's a little lower than the aorta, and the IVC really starts at about L5.
Well, so, if you open, you see a valve in it, you know.
You might see a valve.
Yeah, look in there.
Yes, you can see a little
open it up more,
a little of the tissue on the inside. I think probably might need a scissors to open it up here. But the valve system you find not so much in the big vessels. You find them very much in the peripheral vessels. So even if we did find one, it wouldn't be very prominent, because as you can imagine, if there's a valve inside here, it could influence the pressure within the system. Now, the aorta is that vessel which we said started from T12 and goes down to about L4. And it has some important branches. And from the anterior surface of the aorta, there are 3 major vessels that come forward. And these major vessels go forward to the structures which are lying anterior to the retroperitoneum. And as you know, the structures which are anterior to the retroperitoneum are structures related to the gut. So the gut is going to have 3 major vessels. One of them is going to be the celiac trunk. We probably have a little bit of it right here. Little bit of it right in this vicinity here. Let us see if we can turn it. So in this vicinity, we would have our first big output, which is going to be the celiac trunk. And then a little below it, we'll have the SMA, which is going to be the superior mesenteric. And then inferiorly, we'd have the IMA, the inferior mesenteric. So remember the celiac trunk has been the first one. SMA, superior mesenteric, has been the second. And inferiorly, we'd have the IMA, inferior mesenteric artery. Remember, just incidentally, when you have a kidney, which is a pelvic kidney, some of these kidneys tend to get caught by this inferior mesenteric. So you could find that below it, you have a kidney which is looping from one side to the other. Now, so remember those 3 vessels which are coming anterior. The celiac trunk, the SMA, and the IMA. And then we have some vessels now that are running laterally. They are running both right and left. And coming from the place where the diaphragm, where the aorta goes through, the first vessel that the aorta is going to give off is going to the diaphragm. And because it is feeding diaphragm from the inferior section, that first vessel is going to be the inferior phrenic artery. So the inferior phrenic artery is going to supply both sides of the, well, you're going to have a right and a left input to the diaphragm, right? And then we're going to have vessels which are not body wall related, but vessels that are visceral related. And what visceral do we have down here? We have the kidney, renal, and a little bit above the kidney we have the structure here, which is the adrenal gland. So we have the adrenal gland, we have the kidney, and we also have vessels that are going to the gonads. the testicular and the ovarian artery. Those as well are leaving the aorta laterally. So recapping, those important lateral vessels are going to be the inferior inferior phrenic, and then we're going to have the renal, the adrenal, and the gonadal as lateral branches of the aorta.
And we see some of the lumbar arteries coming off here too.
And then there are some now that are going to leave the posterior part of the aorta, and those that are going through the posterior part don't really have an aorta. On the posterior part here, you can see a couple of vessels going posteriorly, and these are the lumbar vessels. So these are lumbar arteries. So again, just running over the aorta, we're going to have vessels which are leaving the anterior wall of the aorta, and those that leave the anterior wall all go to supply the gut. They're going to be the celiac, the SMA, and the IMA. And then we have those that leave the lateral part of the aorta, and they are going to supply the diaphragm, the inferior phrenic, the renal artery, the adrenal artery, and the gonadal arteries. This one that is going down here, this is a part of the testicular. So in other words, this is a part of the gonadal. This is a male patient, so this is going to be a testicular artery. But if we had a female, then this will be the ovarian artery. Right, so, and in short, we can call them gonadal arteries, right?
What you then associated with those vessels at the roots of the pre and lateral aortic nodes?
Right. And then the last part about the arteries, I remember those that leave the back wall, the posterior wall, and they are going to be all lumbar arteries. And you remember that when we were talking about the source, we were saying that the superior part of the bones are more prominent, and between the superior part of the vertebra and the inferior part of the vertebra, we have the arch, the lumbar arches, from which the source arises. Now the groove between the upper part of a lumbar vertebra and the lower part, that groove is really where the lumbar arteries are going to run. So the posterior vessels are run in that section. Remember as well, in terms of cancers and lumbar, cancers and nodes are very important. Cancers, if we use the presence of cancer in a node to tell us how far a disease has gone. If the disease is confined just to the viscous, just to the organ, let us say it's just confined to the kidney, or just confined to the adrenal gland, or just confined to the prostate, then the disease is at the primary level. But if the disease has spread from that organ to a lymph node, it is at a secondary level. And so the nodes are very important, and the nodes that are related to the aorta, some of them can be linked with the blood vessels. So there are going to be a pre-aortic group, and those that are going to be related to vessels which are at the anterior part of the aorta. So around the IMA, we have a pre-aortic group. Around the celiac trunk, if you can look right here, you can see what a node is. A node is right here. Right. So this, we're going to have those that are pre-aortic in front, and then we have those that are para-aortic. Para-aortic means that they kind of run parallel to the aorta, or they run alongside the aorta. And in this patient, lateral, right, you'll have them running laterally, and running parallel, and running alongside. So those would be the para-aortic nodes. So in this way, this is para-aortic, and we don't know what was going on in this particular patient, but this node is pretty prominent. So we know
the celiac, the celiac.
Right here is you can see the celiac. Right. So here is the celiac trunk. And right, so these are around here, we're going to have nodes related to gut disease. So celiac trunk, remember, the celiac trunk goes to the first part of the gut. So it means that disease is related to from the esophagus right down, including the stomach, including the duodenum. They are going to drain into this area. And then disease is related to the midgut, they're going to drain towards the SMA. Disease is related to the hindgut, will involve the pre-aortic nodes of the IMA, right? So here we have a pretty prominent kidney, and there's a prominence on it, and sometimes you know that these sometimes referred to as dromedary humps. Dromedary being the term given to a camel and the hump that a camel has on it. But from the kidney, we are going to have structures that are going to be going in and out. And that area where these structures are coming out, that's the area of the hilum of the kidney. And if you will remember, within this area, we have the veins. You can see the veins right here. And then behind the veins, we have the artery. And behind that, we have the pelvis of the kidney. So it is like a kind of a VAP. Vein being anterior, artery being in the middle, and the pelvis being posterior, right? So that is going to be your drainage structure. And remember the relationships in terms of the relationship to the source. Now, running inferiorly from the kidney, we have the ureter. And this ureter is very, very important. The ureter is roughly about one of those 25 centimeter structures in the body. And superiorly, the ureter is going to get blood vessels feeding it. So we're going to have at the level of the kidney, we're going to have the renal artery giving branches to the ureter. Inferiorly, you're going to have branches even from the gonadal, that will feed it. And inferiorly in the pelvis, when it goes down to the bladder, then it's also going to get a supply from the vesical arteries. The structure is just going on here. This is the ureter, right? So the ureter is a very, very important structure. And as we go down into the pelvis, it becomes a very dangerous organ for people who are doing surgery that is related to the bladder, surgery as well that is related to the uterus. And so it is very important that you know the anatomy of the ureter. Although it looks small, remember that superiorly there is an adventitia, that is covering it, and some of it is what you're seeing here, adventitia. And then underneath the adventitia, you're going to have smooth muscle. And the smooth muscle, primarily, it's circular on the outside, and inside, the inner layer is going to be a longitudinal layer. So there are two layers of, as it were, of smooth muscle covering the ureter. And as you go down towards the lower part of the ureter, it also gets a third layer, which is a longitudinal layer. So as it is in the vicinity of the urinary bladder, then it is going to have 3 layers. So superiorly, we have 2 layers, the circular being on the outside, and inferiorly, there is going to be the longitudinal on the outside. Now, on a lateral view here, you can see the urinary bladder. And this patient is a male patient. So here is the bladder, which is pretty small, and just inferior to the bladder you can see a nice prostate right here. The cut is not strictly a sagittal section, so you don't really see the ureter. The ureter that you'll be seeing coming out here is going to be the membranous urethra. So this dark area that is down here, this is going to be the vicinity for the membranous urethra. Behind the bladder is going to be the rectum. So these is related to the rectum, and here you can see the bladder. The bladder is a muscular membranous structure, and this structure has a lining which is referred to as a urothelium. If you look at it, you notice that the upper part of it is soft and mobile, but the lower part tends to be pretty rigid. And as you look at this structure, you can see there seem to be holes, as it were, in the bladder. And this means that this man would have had some element of obstruction, because as you look, the bladder wall is pretty thick, and many men, as they become older, they have prostates which are enlarged. The prostates compress the urethra and provide some resistance to the flow of urine from the bladder. And so in terms of the bladder having to do a lot more work, it becomes pretty thick, and we refer to it as being hypertrophied. Now, the layers for the bladder. There is a muscle layer, which is what you see here, and the muscle layer has about 3 layers of smooth muscle. So there's going to be an outer longitudinal, a middle circular, and an inner longitudinal layer. So these are 3 layers on the musculature. And then inside that, we have a submucous layer, and then on that we have an epithelium, which is going to be transitional epithelium, and that has a lot of tight junctions, which help in preventing water or preventing toxins from being reabsorbed into the urinary bladder. So the tight junctions within the transitional epithelium are pretty effective, so that you don't have urine and toxins within urine draining back into the bloodstream. Now, on the bladder, we have the peritoneum. So here you can see the peritoneum. All of this is peritoneum. And anteriorly, the peritoneum helps in forming contributing to some weak ligament.